Hello.
Yeah, hello.
Hello.
Yeah, has the presenter joined?
Yes, yes.
Okay, cool. Then we can start. I think people will join slowly. We can start.
Okay, shit.
Hello.
Yeah, please share your PPT on the screen. Present.
Shall I share the PPT?
Yeah, yes, please. Yes, please. Please share.
Okay, okay, okay. So, is the PPT visible?
Yeah, yes, it's visible.
Okay. So, good evening, everyone. I am presenting a case of Mr. XYZ, a 54-year-old male, resident of Noida, a retired teacher by occupation. And the chief complaints are
Sorry, I can stop you right now. Mr. XYZ means if patient name is, for example, so write initials AP or whatever his name is. Next
okay,
is gentleman. Always use the word gentleman or lady, not male or female. Okay.
okay, sir. Okay,
Please
sir.
go ahead. Please go ahead.
So he presented with chief complaints of distension of abdomen for past 1 year, swelling of lower limb for past 2 months, abdominal pain and loose motion for 7 days, and reduced urination for past 3 to 4 days. So, history of presenting illness. Patient was apparently well 1 year back when he noticed a distension of abdomen, which was painless, insidious in onset, gradually progressive, not associated with any relieving or aggravating factor. He had an episode of blood in the vomitus 10 months back, for which he visited a local hospital and he was admitted there. He underwent endoscopy, and according to him, fluid was removed and he was started on some medications. For from past 2 months, he is experiencing a gradual and progressive swelling. To begin with, it started in feet and currently it has extended up to mid shin. And he also reported some improvement in the swelling after taking medications. From past 7 days, he complains of diffuse cramping abdominal pain that was sudden in onset, on and off in nature, no relieving or aggravating factor, associated with 5 to 6 episodes of loose stools per day, along with decreased urination from past 3 to 4 days. And in the negative history, there was no history of fever, nausea, vomiting, or any yellowish discoloration of eyes or urine, or any change in stool color. No history of chest pain, shortness of breath, palpitation, PND, or thopnia. No history of facial puffiness, blood in urine, any burning sensation while urinating. No history of blood in stool. No history of any confusion, drowsiness, or any change in sleep rhythm. No history of any unintentional weight loss. So, in the past history, there was no history of jaundice in the past, no history of blood transfusion, tattooing, body piercing, IV drug abuse, or TB in the past, no history of any past surgical interventions. There was no significant family history. In the personal history, patient consumed mixed diet, sleep is adequate, appetite is reduced, bladder is normal. He has consumed alcohol for about 20 years, but he has abstained since 2 to 3 years. And regarding the quantification of alcohol, he has consumed
This call is now being recorded.
around 240 ml that whiskey daily. That is around 76 gram a day. So, in summary, this is a case of a 54-year-old gentleman who has history of consumption of alcohol for last 20 years, presented with history of abdominal distension for 1 year, single episode of hematemesis 10 months back, bilateral pedal edema for past 2 months, diarrhea for past 7 days, and decreased urination for past 3 to 4 days.
Hello.
Yes, sir.
Yeah, Mr. This is Dr. Sivaram.
Yes, sir.
Yeah, based on summary, what is your like anything can you say like diagnosis, provisional anything like?
So probably we are dealing with liver disease that is
Okay.
due to alcohol, probably due to alcohol,
Okay.
which has presented with ascites.
Okay. Can you go to first right? What is chief complaints?
So distension of abdomen for 1 year and
Okay.
bilateral swelling lower limbs,
Oh,
abdominal
he had
pain.
okay. He had a distension 1 year back.
Yes, sir.
That time was he not having his pedal edema?
No, sir. The first complaint he told was the abdominal distension.
Okay. Only abdominal distension, nothing else.
Yes, sir.
For how long he was there with abdominal distension?
Sorry, sir. What?
For how long he was there with abdominal distension at home?
Sir, from 1 year he's having this abdominal distension. Before that, he was completely all right.
Okay.
So
Yes.
today he came for this abdominal distension complaint to your hospital.
No, sir, with complaint of reduced urination.
So what sir is trying to tell you is basically chief complaint is mainly usually for which complaint he came to the hospital right now. I think that is what you are trying to ask.
Yeah, yeah,
Uh,
yeah. The
yeah.
thing is like this can be presented like two ways actually. This is like which what was the main complaint for the patient that is presenting now
Yeah.
versus
Okay.
like direct and explanation of entire disease as a whole with since the onset of the disease. That
Yeah,
two thing
so
that one thing I
I
want to
think
mention.
how you can do this is you mention as a chief complaint for which he has come to you right now, and
Exactly. Yeah.
when you are trying to say in HOPI, you start saying that patient started having complaints actually about a year ago, and this
Okay,
is
sir.
how it all started, and currently
Exactly.
patient is in this condition, and that is why he has come like this. So
Why?
your
Because
HOPI is actually fine, but chief complaint cannot be 1 year.
yeah.
Okay.
Why?
Okay.
Because between the main the abdominal distension and the pedal edema, total nearly 8 months is there. Isn't it was what was there in happened in 8 months in between?
Between
So that
that,
is
sir, after around 10 months back, he had an episode of blood in the vomitus.
Okay, that means like 1 year
whether
duration of
did he had any ascitic tapping in this 1 year? Hello.
Yes,
hello.
yes, sir. The
Uh,
when
yeah,
he got that hematemesis episode, he was admitted in the hospital, sir. There he underwent this tapping.
The thing I want to convey is explaining entire like 1 year duration of 1 year course is very difficult in this cheap complaint itself.
Okay, sir. Okay.
And in between patient is like we don't know what happened in between like 6 to 7 months. He was like 1 year back he had abdominal distension, and in between we don't know one single episode of bleed, and now he is having a pedal edema and decreased urine output. This might be like taken as a cheap complaint. Pedal edema and abdominal decreased urine output. Then you can, when as sir said, when you elaborate this thing, see history of present illness, you can explain that everything started 1 year back. So and so what happened. Entire duration of 1 year course, you can explain that history of present illness.
Got it, sir. Yes.
Yeah. And one more thing, do you like you are telling this towards liver hepatobiliary system, right?
Yes, sir.
Uh, as an abdominal distension for 1 year and then pedal edema for after 8 to 10 months of development of abdominal distension, having pedal edema, is it expected in hepatobiliary system? Anything?
No, sir. Generally, what happens is pedal edema occurs prior to the abdominal distension.
Is it? Okay, let me make you some this thing. pedal edema started and then extended to abdominal distension. What might be the causes? And abdominal distension progressing towards pedal edema.
So
What are the
if
causes?
abdominal distension, that is ascites precox, sir. If abdominal
Okay, very
distension
good.
comes before the pedal edema,
Okay,
so then the causes can be, sir, constrictive pericarditis. It
okay,
can be tubercular ascites.
okay,
Peritoneal carcinomatosis can be a cause for that.
okay.
Mainly the right heart related causes would be
So
enlisted in this.
abdominal distension starting with then pedal edema later on.
Yes, sir.
So what happened? What happens in cirrhosis or something like liver related ascites?
In cirrhosis, the pedal edema would come first, sir.
Okay, then
Then he would complain of abdominal dissension.
is it is it true? Like whatever you told about ascites precox is true. Abdominal distension. What is ascites precox basically?
What is ascites, sir?
What is ascites precox?
When ascites develop prior to, sir, pedal edema.
Yeah, mostly ascites precox is generally patient will be having so much time with ascites only. Pedal edema develop very much later.
Yes, sir.
Yeah. What are the causes like for ascitic precox? Ascites precox is mimics like hepatic venous outflow tract obstruction, right? It's like
Yes, sir. Post
yeah,
hepatic causes would be under
yeah,
there.
that's exactly commonly predominantly explained for constrictive pericarditis actually.
Yes, sir.
But in cirrhosis, portal hypertension ascites also, you don't expect pedal edema to start first and extend to abdominal distension. Generally, start as abdominal distension only, and parallelly, more or less parallelly, if the patient has pedal edema also. It's not like starts with pedal edema and extends to abdominal distension.
Okay, sir. Okay.
Yeah.
So so the thing here, what has happened is because patient told you that I am having abdominal distension since 1 year and edema since 2 weeks or whatever time, you are also mentioning the same, and that is why this confusion happened right now, and you are now in a situation where uh, you have to define why ascites came first and epididyma came later, right? So the
Okay, sir.
thing to avoid this in exam is you start telling patient, पहले तो आपको पैरों में सूजन रहेगा ना, स्टार्टिंग में थोड़ा थोड़ा था, धीरे धीरे बड़ा. You make sure that patient understands
Exactly. Yeah.
that
Okay, sir.
there was some edema previously also, which
Patient
was
might not be
coming and
noticed
going or
that.
something. Yeah, patient will not notice because it is
Yeah.
not troubling him a lot
Yeah,
at
that's
that
what
time.
exactly. That
Now
might
it
have
has
happened.
started troubling him.
It's
Yeah.
not like patient is not having pedal edema. Some sort of pedal, by time full blown edema, patient might be given some medication to reduce it. So that patient might not have noticed problematic pedal edema mostly.
Okay, sir.
So in your history, you should try to make sure that ultimately what you are trying to say is edema was there since 1 year only or even before that. And
Mostly
now it has worsened to the level that he is having trouble because of this edema.
Okay,
in
sir.
cirrhotics, abdominal distension and pedal edema mostly starts parallelly. And the other way around, pedal edema starts predominantly and then progressing to ascites, something like it's some other cause you should think of, like renal predominantly.
Okay, sir.
Yeah.
Okay. So you
Yes.
can try to modify history, but make sure that your patient is also understanding that what you
So,
are trying to
yeah, this
manipulate.
point is
Like
very much important. You can't show so much discordant between these two symptoms.
Got it, sir.
okay.
Yes.
Okay, then one more thing. How can you say that this is related to hepatobiliary system?
Sir, because he had this episode of blood in vomiting also,
Okay, good.
and abdominal pain is also present, and diarrhea is also present.
Pain, diarrhea. How can I explain diarrhea with ascites?
So I think your biggest answer should have been he has significant alcohol intake history.
Yeah, that's what.
Okay.
Okay, sir.
Yeah.
Because
That
patient is not having jaundice.
Yes, sir. Jaundice was absent.
One thing, the patient, since patient is not having jaundice, it used to be somewhat difficult to attribute everything to GI pathology, like as in hepatobiliary system. But still, patient is having significant alcohol mostly towards like hepatobiliary system. That thing you can tell.
Okay, sir.
So, do you expect patient to have cirrhosis without having any episode of jaundice? at any part of his life?
To have ascites without jaundice?
So basically, what is the cause of ascites? Some portal hypertension or cirrhosis, something, right?
Sir, I didn't get your question.
Are you
Can
get?
you?
Yeah. Do you expect the patient to have cirrhosis, develop cirrhosis or ascites without developing jaundice?
Yeah, yes, sir, it can happen.
Okay.
If it's alcohol induced, it can happen, sir.
Yeah. Chronic liver disease need not have present with hepatitis always. So cirrhotic and burnt out livers won't manifest with jaundice. Thing is,
Yes,
on
sir.
top of that, anytime patient takes binge alcohol intake or any hepatitis, active hepatitis, then only patient will be presenting with jaundice or any sudden onset of jaundice in a patient with cirrhosis. You expect to have hepatocellular carcinoma like complications, something like complications.
Okay, sir.
Yeah. Okay. Look on.
So what does development of jaundice in a patient of ascites, I mean chronic liver disease, tell you? What does it signify?
Yeah.
So it can indicate, sir, decompensation, or it can indicate, sir, acute on chronic liver disease.
So what makes you what could be the acute insult? In other
So
words.
it can be any viral cause, or it can be any
Okay. Good. Okay. Good.
drug induced cause.
What drugs do you expect?
So any drug induced liver injury, sir, most commonly by the routine antibiotics, sir, moxiclav that we usually prescribe.
Okay.
Yes, sir.
No short forms now
No.
onwards. No short forms. Okay. Mox
Okay.
name. You have to use full form only. Okay.
Yes, sir.
Tell common things like hepatitis, viral infection. Okay. Patient
It
commonly
can be
what
So
they
any
do.
sepsis can
infections,
precipitate
basically
that.
any infections. Yeah. Not only viral infections, any infection can precipitate and can lead to sudden decompensation with increase in bilirubin, right?
Yes, sir.
And patient tends to take alternative medication commonly whenever they know that they are having some problem with the liver. That history you should ask definitely. Okay.
Very important. Alternative medicine you have to mention.
Yeah.
Okay.
Okay,
One
sir.
more thing, rapidly worsening jaundice, you always keep in mind of hepatocellular carcinoma.
Hepatocellular carcinoma. I wanted to listen to hepatocellular
Yeah.
carcinoma.
Yeah. That's
Sudden onset of development of jaundice in a known case of CLD, you have to mention as a later causes of sudden onset development, that is hepatocellular carcinoma, not as
rapid
a first.
deterioration.
Yeah. But it should
Rapid
be there in your
deterioration of
DB.
underlying CLD in form of progressive worsening of ascites and worsening of jaundice. And, we should always keep in mind of hepatocellular carcinoma.
Okay, sir.
Go on.
So negative history.
No, it's still there. Just,
Wait. Yeah.
basically, gastro case is mostly you'll stuck up in history only because there won't be much anything in examination and all.
Did you ask for alternative medicine in history in your anywhere in your history? Alternative medicine history?
No, sir. I should have asked for the alternative or herbal medication.
Yeah,
Yes.
you should ask.
Yes, sir.
Go to the
Okay.
bleed
Even
part.
childhood
Second.
jaundice or all those things. So, see, this many negative history, I really, I really don't like so much, and even some consultants don't like so much of negative
Yeah.
history. You don't need to mention each and everything which comes to your mind. You cannot rule out each and everything. Important things needs to be there. Okay. So
Can
I
you
understand
elaborate
that you are trying. Yes, go ahead, please.
yeah, can you elaborate that negative history? Why do you take the negative history or substantive negative history?
Okay, sir. History of fever in a case of abdominal pain in and ascites with the background of ascites to rule out, sir, SBP, spontaneous bacterial peritonitis.
Is the patient has pain?
Yes, sir.
Okay. Is he having pain abdomen?
Yes, sir. Diffuse
Okay.
cramping,
Yeah.
abdominal pain. I already
Okay,
mentioned.
got it. Yeah.
And yellowish discoloration and the jaundice symptoms, to ask about any acute on chronic liver disease, any
Okay.
acute insult, viral hepatitis.
Okay.
Yes, sir.
See,
And
if it is there, you have to mention it. It's okay. If it is not there, I don't think it is compulsory to mention everything. Okay.
okay, sir.
If it was there, you already said there is no jaundice, and you are I mean, I don't know here only if you mentioned or previously also. If in past history or any history, if there is no jaundice, don't keep mentioning it again and again. Chest pain, restlessness, palpitation. Why did you ask?
Sir, to rule out the cardiac causes of any pedal
Do
edema
you think this
because
is cardiac reason of this whatever 1 year these things are happening? Do you think it is cardiac origin?
no, sir, just to rule out any cardiac cause of pedal edema, so I asked the cardiac history.
Yeah. So
No,
you
which
think ELD was already there and now he has developed cardiac disease also? That is what you are trying to say? Is
which
there
sudden
any thing in your history that tells you that this can be cardiac
No, sir.
other than edema?
No, sir.
Yeah, I really think you should mention it. It's okay. What you should do is you keep it in your notes, you write it there, but don't mention everything
Okay,
because
sir.
you will stuck there.
one
Okay,
thing is
you will
like
get stuck.
writing, explaining, telling about breathlessness is okay. Again, palpitations, chest pain, PND, are and these things unless we drag you towards again CVS. Your mind is fixed to liver hepatobiliary, right? Here,
Okay,
SOB
sir.
is not there. That's okay. Again, SOB, if SOB is there, then you have doubt of whether it is PND or arrhythmia, platypnea. These things should come. When there is no SOB, what is the point of again PND and arrhythmia?
Got it, sir.
Next is facial puffiness, blood in urine, burning sensation, burning in urine. So, do you think this patient is having cardiac, I mean, renal issues? That is what you are trying to rule out, right?
Yes, yes, sir. That these both history actually asked to rule out the
I
cardiac and
understand your
renal cause.
point. I understand your point. But more important histories here would be negative history of complications, negative history of etiology, and
Exactly.
negative history of complication. Patient is not having reduced urine output. That is important. Or if he is having urine output, the reduced urine output. That is important part. But ruling out nephrotic syndrome or whatever nephritic syndrome you are trying to rule out here is not required.
Exactly.
Okay,
See,
sir.
negative history is two types basically. Negative history is what related to your particular system, what you are going to think. When you say ascites or something, then itself you are telling no evidence of no history of jaundice, not no evidence of like regarding renal output and all. Explaining there itself that is fine. Again, as sir said, again you are explaining about nephrotic syndrome and all, not needed actually. Here nephrotic syndrome and all is not at all in our picture, right?
Got it, sir.
Yeah. Negative history is particularly related
Important
to
thing
your
would have been
yeah.
encephalopathy history to be ruled out
Yeah,
here. So
yes.
maybe you can write here that he is not having sleep disturbances here only. That is okay. But writing kidney and heart here, I think it's not required. Even if you are worried that I need to put it, you put it in your notes. You don't utter it. If consultant asks you, okay, did you ask for this? You say yes, sir. I have written it, but I forgot to mention while presenting. That's it.
Okay,
Negative
sir.
history is related initially that negative is related to particular symptom, chief complaints, then towards complications, then towards any other systems to rule out.
Like cardiorenal syndrome, so renal complications are not there like that. I mean, hepatorenal syndrome, so renal. So basically, complications you have to rule out. That is more important here. Okay.
Okay, sir.
Yeah. So unnecessary negative history to be avoided because I can ask you 100 things. I mean, वो भी
Yeah,
negative history नहीं लिखा, ये भी नहीं लिखा. You cannot mention each and everything in negative history, right? So important
Yes.
things only needs to be discussed. Okay. Otherwise,
Okay,
your
sir.
Wi-Fi will get diverted from where you want to take it, and instead of that, it will go to some other path only.
Yes, sir.
can you come to the second that the chief complaint blood and something is there no? First blood. Last point from past. He had some blood vomitus.
So second point.
Yeah, second point. Yeah. He had blood vomitus 10 months back, which he visited local hospital and admitted, underwent endoscopy and fluid was removed and was started on medication. So what could be it is?
So maybe he had an episode of upper GI bleed,
Okay.
although there were no documents available to
How severe
support.
the bleed was? Did you ask anything to know the
So
severity?
I was not able to quantify because the patient couldn't remember.
By any other means you can ask.
The amount of blood, sir.
Yeah,
Severity of
did you
bleed.
require any blood
Severity.
transfusion at that time?
Yeah,
So,
exactly. Severity of bleed you can assess. If patient cannot tell,
So
could
for
not tell that
severity, we
amount.
can say that he required 2 or 3 pints of blood
Yeah,
at that time. That means you know that it was a severe bleed,
severe.
or he did not
Any
require any blood transfusion. That's how you can quantify, even if
any
patient does not tell you.
hypertension, any altered sensorium, any requirement of blood transfusion, any faster melena, severe melena, bleed or persistent bleed, these are all indicates to severe.
Okay, sir.
Yeah,
Okay.
that
Yes,
in
sir.
that way you
Got it.
can tell. So the bleed, he had transfusion of blood transfusion. So that bleed is severe. So
Yes,
these
sir.
things help you. It's like what is the cause of severe this much severe bleed in a patient with underlying suspected liver disease? What could be the cause?
So maybe due to esophageal varices,
Yeah, well,
bleeding esophageal
that is
varices.
most probably varicose bleed. If the bleed is minimal or something like a transient, like without any transfusions, some transient 10 15 ml streaks of blood after binge intake, that could be because of post binge intake malarial something like. So both things definitely different.
Yes, sir.
So varicose bleed means patient is like already decompensated.
Yes, sir.
Yeah. Okay. Go on.
Shall I proceed to
Yeah.
examination, sir?
Yeah.
So one thing,
Yes.
in your history, what I would do in your history, start with 1 year back history, slowly progressive advancement. What I want to understand is how many times he underwent ascitic tapping, how many episodes of varicose bleed or these things require, how was the progression that. So the problem here is this episode of blood in vomitus, I would keep it where we are keeping the negative history, no? That in this last 1 year patient was had one episode. So what you can do is make a heading out of it that there was a one episode which required all these things. There was another episode which required all these things. What you want to show is the chronology that how fast his systems are deteriorating. Initially, it required every 2, 3, 4 months. Then now it is every 2 months like that. The chronology should be better than what it is right now. But otherwise, you have done good history and all. The points are very clear, but the chronology, I think you should try to keep it more that it becomes like a story to the
Yeah. So that
listener.
we can assess the severity, we can assess the progression of the disease. How disease is going extending now.
Okay, sir. Yes.
Okay. Go ahead.
Yeah. Can you summarize now? Like after all this discussion, please summarize.
Importance of family history in case of CLD.
Sir, to rule out any familial disorders like alpha 1 antitrypsin, Wilson, hemochromatosis, or even HCC if familial.
Yeah. Tell common things like alpha antitrypsin is not that common. Wilson's hemochromatosis first thing.
But good that you should try
Yeah.
to utter 3, 4 things first, which you did well. So that's okay.
Good.
Okay.
Yes, sir.
Summary. So instead of who has history of consumption of alcohol for 20 years with significant alcohol
Significant.
intake,
Yeah.
that's
Okay.
a simple one with significant alcohol intake, or if somewhere else if it is smoking with significant history of smoking, yes, sir. That way.
Okay.
Okay.
Yes, sir.
Now presented with complaints of abdominal distension for 1 year, requiring ascitic tapping once, one episode of hematomesis,
Hematomesis.
requiring variceal bleed, ligation, whatever was done, or endoscopic procedure. Now worsening in the form that it is presenting with pedal edema as well as decreased urine output. What are your differential diagnoses that we already discussed? And etiology. So basically, point is in summary, what you are trying to say is etiology, which system is involved, that is hepatobiliary liver basically is involved, and what current complications patient is having of that system. That is what is your thought process regarding that. This 3, 4 things should come in your summary. That is very important. And DD, if there are DDs. So your what are your DDs because of all these things? Okay.
Yes, sir.
Okay. Anything else, Dr. Shivaram?
Yeah. Can we ask differential here itself? Any possibilities? Like? No.
Sorry.
Can we ask differentials here?
Yeah, we can ask differential. As of now, differential will be CLD. So
Surely, but like why that sudden worsening of pedal demand?
yeah, definitely.
Yeah. That's what differentials like underlying CL and the obviously the This is syndromic diagnosis, chronic liver disease, probably be secondary to alcohol intake. That is known patient. That is already known thing that is happening for last 10 months. Now, why suddenly it worsened?
So now he's having pain in the background of ascites.
That
So
things you should tell. Possibly the differentials are
so the differentials could be, sir, one could be SBP.
okay.
One could be, as he is consuming, has a history of consumption of significant amount of alcohol. It can be due to alcoholic pancreatitis. And
Alcoholic pancreatitis. Okay.
He's still using alcohol. He's not stopped.
sir, from past 2 to 3 years, he's abstained from that consumption.
Then
Now you
yeah,
think it is
is
pancreatitis is because of alcohol? If at
No,
all, if
sir.
it happens.
Unlikely it would be, yes, sir.
no,
Yeah,
don't
so
use
don't
that. You will
utter
be in
such
soup
things.
again. No, don't use such things now.
Yeah, you are trying to put your leg in a
Okay.
emergency right now, so don't put such things. Okay,
Okay, sir.
you were going well, and suddenly alcoholic pancreatitis came in between, so that was not required.
That is why I asked actually. Something like uh,
So can
yeah,
it be due to any incarcerated umbilical hernia, as the distension was significant?
The pain.
Yes, sir, abdominal
You
pain.
tell us.
No,
you
I
tell.
would
That's
consider
what.
it as a differential.
Okay,
Okay.
okay. Let us take. Let us think. Your first differential is SBP, second differential acute pancreatitis, something like third differential incapsular umbilical hernia. You substantiate with what history, based on what history was you were telling these all. See, as sir said, pancreatitis to say pancreatitis, patient is not didn't take any alcohol recent without any like to have pancreatitis. Patient should take recent alcohol, binge intake or something like. So that is pancreatitis out of chance now. Yourself telling incarcerated umbilical hernia. So how do you telling it? How do you tell it? One is
What are
pain.
things
Then
in favor and what are things against? You tell me.
exactly.
So due to abdominal distension, the significant amount of abdominal distension, he can get
So
complication
Do
of
you
that.
get uniform distension or something like incarcerated
No,
umbilical
sir,
hernia? What?
uniformly distended.
Okay.
Yes, sir.
What are prerequisites to get umbilical hernia?
Sorry, sir, what?
What are the prerequisites to develop umbilical hernia? That okay. Patient is having ascites, so that you are telling might be developed umbilical hernia. You want to tell that?
have you seen any patient developing umbilical hernia?
No, sir, not that
I mean,
common.
maybe what you are trying to say is recurrent ascitic taping was done or something. I don't know. But otherwise, I
Does
don't
the
think
patient
so.
complain about vomiting or any?
No, sir, there was no vomiting or any signs of intestinal obstruction.
Okay, then
Yeah, so
that is going
that
against
is
again.
your answer.
Okay,
Hmm.
sir.
Yeah, exactly, that's the point. And that is not, you should definitely not tell that.
Okay, sir. Okay.
So
No,
not
no.
giving too much reading is okay. Yesterday also, I think, I don't know, last cardiac case also, I said this, I told the same thing. You keep your differential diagnosis
Ah,
open. Don't go to any specific things.
yeah.
It is a
If you're not
chronic
having much
liver
TDs, that
disease.
is also fine.
Yeah, that is fine. Definitely, that is fine.
What we expect is like already known patient of CLD worsened sudden rapid recent worsening. That could one differential could be because of SBP is right. And patient might be having acute GE. Acute GE worsening is vascular this thing status. He might have renal compromise because of acute GE.
Okay, sir.
That
You
you
said
can tell.
diarrhea was there, right?
Yeah.
Yes, sir, diarrhea was there.
What?
Yeah, so acute gastroenteritis makes more sense, no?
Yeah.
Yes, sir, dehydration induced, yes.
And
Yeah.
what are the other kinds of sudden worsening as we discussed earlier also?
So any
Who is
infection?
presenting Arpan, no? Who,
Yes, sir.
Arpan, yeah, Arpan, most common things only you should utter in exams.
Yeah.
No
Okay,
rare
sir.
things, especially at this phase where you are in history only, at the end of history.
And
No rare things are required. Just very most common things which you routinely see ascitic patient coming with fever, with abdominal pain, mostly it's SBP. That is how we discuss also, no, in rounds and all.
yeah.
That this is
Examiners
suddenly
expect very
compensation.
common things only. They won't expect any such rare things. Examiners expect basically discussion. Pancreatitis and hernia is like definitely you should not tell at all. You'll be in soup definitely.
Got it, sir.
So yeah, what is cause of worsening means the poor compliance of drugs also might be there. So it's already known.
Infection can be a cause, sir.
Yeah, exactly. Infection already we discussed. See SBP. What are the
So,
common infections to develop in patients with CLD, cirrhosis, or ascites?
So, if we are thinking in terms of SBP, then
Yeah,
the common among that is gram
no.
negative.
What are the common infections, common source of infection, site of infections you expect in patient with cirrhosis? One is SBP, two is cellulitis, three is UTA. These are very common.
Okay, sir.
Yeah. Second thing is drug, poor compliance of drug or development of any complications like HTC. That is for ascites and jaundice, not for a decreased output. And patient is having recent, he has history of recent acute GE. That might be worsening his renal compromise as we discussed. These things you should tell in differential. That's all. You should not go beyond these, but better.
Okay, sir.
Is it okay, Dr. Deep?
Definitely, very true. Okay, I think we can move ahead now.
Yeah.
So, in the shall I proceed?
Yeah, go on.
Okay, so in the physical examination, general physical examination, the patient has lean built, conscious, cooperative, well oriented to time, place, person. Pulse was 84 beats per minute, regular rhythm, normal volume and character, no radial or radiofemoral delay. All peripheral pulses were well felt. Blood pressure was 110/70, measured in the right arm. Respiratory rate 22, thoracoabdominal type. JVP was normal. Afebrile 96% SpO2 on room air. Weight was 52 kg, height 163 centimeter.
Okay,
General physics.
just 1 second.
Yeah.
Pulse, I really again don't think you have to mention in detail. You know that this is not something cardiac. So again, maybe you should mention it in your notes, but don't talk it. I mean, no, this much is not required. I think
Can I
volume
add?
is one important thing.
Yeah.
Dehydration you want to see and all, but other things are not required. Radial, radiofemoral delay. Do you expect this
Yeah,
right now?
that thing is not
No,
required, I
sir.
think. It's not, since it's
Okay.
not the cardiac this thing. What about
Next
pulse
is
rate?
blood pressure. How do you? So tell me, how do you measure blood pressure? Hello.
Hello.
Yeah, can you hear us, Arpan?
Hello.
Hello.
Yeah, you are audible.
Am I audible?
Yeah, you are
Yeah.
audible. How do you measure blood pressure?
So we can measure by palpatory oscillatory method.
Mm-hmm.
We inflate the cuff by tying the cuff at arm level, and we elevate it up to around where the sound disappears. So slowly by
Do you
2
take
mm.
any pre? I mean,
Radial
before
artery
checking your
will
blood pressure, do you check anything? Do you ask anything? Do you do anything?
no radial artery, sir. We will palpate.
Even before that, what is the ideal way of measuring blood pressure?
So with patient sitting in supine position and no
Sitting in
consumption,
supine position.
sitting in within sitting position
Sitting
and
position. First of
no
all, I wanted.
consumption.
Yeah, it
Yes.
is sitting position. I last case also I asked the same question. Cardiac case was there and somebody mentioned supine position. You cannot make mistakes in these things. Okay, these are very basics. You please before going into exam, because this only one or two questions will be asked here, and if you get stuck there, then it is not good. So these basics must be very clear. So blood pressure, whenever somebody asks, patient should not be having any caffeine or something within less 15 minutes. He should rest for 10 minutes. Then I will ask him to sit relaxed. You will not do all these things in exam. What I'm trying to say is this is how you are measured to supposed to measure blood pressure. Okay, that question's answer should be very clear. Okay.
Yes. Yes, sir.
So then he was, I mean, in sitting position at the same level of heart, whatever we say, all these things. And then you go to this auscultatory palpatory method, everything. It is in sitting usually. That is what I understand. So please don't mention supine. Okay.
Sure, sir. Yes.
Yeah. Next
Okay.
was
What,
respiratory thoracic. Yeah.
what about
Go ahead.
pulse? What about pulse? Is it okay to be 84? Can you explain anything? Patient is like probably had a varicose bleed and some 8 months back. They might be putting on some drugs, right?
Yes, sir. On
Mm.
beta blockers
Yeah.
probably.
With beta blocker, do we expect the pulse to be having a 84?
Unlikely, sir. It should be
Is it?
on the lower side.
Yeah, should be on lower. Then you are, if not, your beta blockers might not be working, or he is not taking. This is the
Yes, sir.
possibility. Okay. Yeah, go
Yes.
on.
Shall I proceed with the general physical examination, sir?
How did you measure
Uh,
temperature?
yeah,
Just
and you mentioned febrile. Is it okay? I don't think like you have to measure your right temperature.
No, it
Go.
was 99. So we should mention the value.
Yeah,
Okay, sir. Yes.
yeah.
right,
Because you
right.
mentioned febrile, I wanted to ask how did you measure and all these things. You will get questions because of such things. Okay.
Yeah,
So
better
we
you.
want to move ahead
you
as soon as possible, as fast as possible from this part. So okay.
each and every single
Yes, sir.
point of general
Noted.
examination is invites many questions. Just like I asked about the blood pressure, you can stuck up with BP also, as that
Okay, sir.
discussed now. Okay, go on, go on.
So in the general physical examination, pallor is present. No icterus
How much
cyanosis.
pallor?
So
Hello.
Yeah, is there
yes.
any grade?
Yeah. So don't get too much this thing. I am just trying to give you as many questions as possible that can be
Yeah,
asked, and you
it's
should be
okay.
able
Here,
to.
like
Okay.
Yes,
So
sir.
yeah, there is some severe, there is, so clinical examination, you can just say, so you should know how to check for pallor, which all sites to be checked for pallor, how to grade pallor based on clinical examination. You can only say whether it is severe or not severe, and all these things you should be able to give answers to. Okay, next.
Yes, sir.
Icterus, how you check for icterus? Which all sites you check for icterus? How can you say what is deep jaundice? What is deep icterus? All these questions you should be knowing. These are basics. Okay.
Okay, sir.
Anything else? I think we should give them more questions than asking. So anything else, Dr. Sivaram, from this?
yeah, go on, go on. Like
Yeah.
clubbing, what are the kinds of GI kinds of clubbing again? Some like, these
Yeah.
are routine questions basically, but you should be very clear about all this. The world examiners these will be asking repeatedly such questions.
It Shall I tell the answer, sir?
Yeah,
You
tell.
can tell. Yeah.
So clubbing in GI cases can be due to HCC, can be in hepatopulmonary syndrome,
Okay.
Yes.
Yeah, again,
IBD,
yeah.
celiac.
Okay.
Bilateral
Okay.
pitting
Fine.
pedal
Fine.
edema.
Fine. Yeah.
Okay. So pedal edema till what? You
So
said it was pedal
till
edema.
shin.
In history, you said increase in edema recently something, no?
Yes, sir. The edema. It was till shin, sir. Mid shin.
Oh,
Yeah, so I think if it is more severe than what we usually say, pitting edema, thoda bahut. If it is more severe, I think you should try to say that in detail. I mean, try to say. I mean, you think
there are two,
how
three
to
types
look
of
for edema?
different types of grading are there for pedal edema. You
Yeah,
can
yeah,
like you can be clear with any one of those. That is fine.
yeah.
Yeah, okay,
But
go on.
you should be knowing what are those grading. I mean, if you
Yeah,
say
yeah.
those gradings, you should be knowing what is mild, moderate, severe, whatever. Okay. So
Okay,
Some
sir.
just
gradings
have
has
some
three,
idea
some
that what
gradings
is
has four, something like that. But be clear with one at least.
and how to look for edema. Please make sure that you know the answer and you can say it out immediately very fast. Okay.
Yes, sir.
No signs and stigmata of CLD except spider nevi.
Okay.
Dr.
Okay.
Sivaram,
Yeah, yeah. What are the signs and stigmata of CLD first?
So starting from above downwards, there can be alopecia.
Okay.
Can There can be parotid swelling. There
Here
can
two things are here. Stigmata of chronic liver disease is different. Stigmata of chronic alcoholism is different.
For alcoholism, sir, the
Yeah.
major things are Dupuytren contractures, palmar
Okay.
erythema,
Okay.
and parotid swelling, sir.
Yeah.
very good.
These three are for chronic alcohol. Stigmata of chronic alcohol. Okay.
Sorry, sir, what?
Yeah, these things are chronic alcohol. Good, good.
Yes, sir.
Yeah. Stigmata of chronic liver disease.
It includes alopecia, gynecomastia,
Okay.
Dupuytren contracture, palmar erythema,
Okay.
testicular atrophy, caput
Okay.
medusae, uh, and smells of fetal hepaticus
Now,
can be there.
what is the mechanism of gynecomastia and the loss of
So it is due to hyper estrogenism, sir, because
Right.
liver is damaged, so estrogen doesn't get metabolized.
Yeah, again theoretical, but be particular about it. Okay. You saw spiders, the 5 to 6 spiders. Okay, where
Yes,
do you
sir.
see spiders commonly?
Sir, it is generally seen on upper part of chest and upper back, sir.
What is spider? What is this? What is there in what is that structure?
So this is actually central arteriole is visible. When we try to compress that with a pinhead or a slide, diascopy slide, then the flow is seen, sir, from
Have
center
you
to
ever studied
periphery.
that you compress with blank with the central acting head and
Yes, sir.
you see you felt, you examined.
Yes, yes, sir.
Okay, fine, fine. What is significance of spiders? Spiders commonly in just as you explained, like from predominantly in uh,
In the
SVC
SVC
area.
territory,
Yeah,
basically.
exactly. SVC territory you should tell the world. What you should tell. Okay. What is significance of having spiders?
So spider nevi, first is that if it can indicate high mortality in alcoholic hepatitis, and sudden disappearance of spider nevi can indicate UGI bleed,
Okay, good.
and florid spiders with clubbing, recent onset clubbing, can favor us in the diagnosis of HPS, hepatopulmonary syndrome.
Okay. Somewhat good. Okay. Fine. The more number of spiders tells you that patients having more like significant severe portal hypertension. To say more than 10, like 8 to 10, more than 10, like patient is high likely to have a bleed near future. It's like basically severity of expensive severity of portal hypertension.
Okay, sir.
Can you explain? Can you have? Can you see spiders apart from any other cause other than CLD?
Yes, physiologically it can be seen in pregnancy,
Okay, good.
or pathologically in thyrotoxicosis or Cushing disease, or on a female who is taking OCPs.
Yes, exactly. OCP. And then pediatric age group. You commonly see spiders.
Pediatric. Okay, sir.
Yeah, children also you see commonly, but transiently as like pregnancy, as these kids grown adult, then they will disappear. And what's the
Okay, sir.
close differential with the spider?
Sorry,
Uh,
sir, I don't know.
cherry red spots.
Okay, sir.
Yeah, cherry red spot. These are like you can see anywhere like upper limbs and trunk. These commonly mistaken as spiders. You see that
Okay.
sign on sign name Campbell D. Morgan sign, something like that. You should keep in mind this. You should
Yes, sir.
differentiate with cherry red spot. You should ever tell it is cherry red spot or spider. Cherry red spot doesn't have the central arterial. Just it's like something just like a dot like red dot like.
Okay, sir.
Yeah. Go on.
Very good. Cherry red spot, you should know how to differentiate it from spider nevi. Okay, that is what. Okay,
Yes, sir.
go ahead.
Oral examination. The oral hygiene was adequate. No bad breath or no tobacco staining was seen. In the abdominal examination, on inspection, there was generalized distension of abdomen and flank fullness. Umbilicus was everted. No umbilical hernia or other hernial orifices were intact. Superficial veins are visible, dilated. All regions move equally with the respiration. No divarication of recti. No sinuses, no scar mark. In palpation, there is no tenderness or local rise of temperature, no guarding rigidity. Dilated veins were present predominantly on the periumbilical site, and the flow was away from umbilicus. Liver was not palpable even by the dipping method. Spleen is palpable. That was 4 centimeters from the left costal margin towards the right iliac fossa, and the surface was smooth, firm in consistency, non-tender, and notch was felt. Kidneys were not palpable.
Okay, wait. Now, what is normal flow of venous system here?
So it is from center to periphery, from umbilical center to periphery.
Normally, what do you expect?
So normally it is from center to periphery, but in portal vein it gets more visible due to the distended veins.
Yeah, good. It's, flow is same, but it enhanced because of the portal hypertension.
Yes, sir.
Okay. Okay. What is Caput medicine?
Caput medusae, sir. These are the protosystemic anastomosis site. That is the combination of paraumbilical vein and epigastric vein.
Yeah, recanalization of left parambilical vein it is.
Yes.
Okay. You could not palpate liver.
No, sir.
Okay. You have to palpate spleen.
Yes, sir.
Okay. Okay. Next.
Shall I proceed, sir?
Yeah, go ahead.
Okay. On percussion, liver dullness, the upper border was felt in the mid fifth intercostal space in mid clavicular line. Lower border couldn't be appreciated. Shifting dullness was present. Fluid thrill was absent. Drop space there was dull note.
Typical
And
is present.
yes, shifting dullness was present, but fluid thrill was not there.
Then you can shift the patient towards some other opposite side. You can able to percuss liver, right? Lower border of liver.
But sir, I couldn't appreciate the lower
Okay.
border. I
Okay.
tried by both the method, even by dipping method also, sir, but I was not
Okay.
able to do so.
Okay. Liver border, upper border is at fifth into
Yes.
you felt liver dullness. So what if you get in 6 or 7 space?
Sir, in sixth space it can be normally found. Fifth and sixth intercostal space it is normally found, sir.
Okay. What happens in hydrothorax?
Uh, in sir, we won't be able to appreciate the upper border also, sir.
Yeah. Then what? Anything you can. So how to differentiate whether it is like hydrothorax is there or not?
Sorry, sir, I don't know that.
Okay. What is tidal percussion?
Okay, so we ask the patient to deeply inspire, sir.
Yeah.
And
Okay.
for if the note changes, then the tidal percussion is positive, sir.
Exactly. Okay. In that way you can differentiate. Okay.
Okay. Yes, yes.
Yeah. Okay. So drop space again. Why drop space is dull?
So maybe due to maybe the physiologically it can be maybe the patient has consumed food, or pathologically maybe there is splenomegaly as in this
You tell
case.
directly what is this. Splenomegaly is there, no?
Yes.
When someone asks randomly what is the cause of drop space obliteration, you tell that so start from patient taking food and all. You have in case of CLD, portal hypertension, splenomegaly is there. You tell directly what the cause of the obliteration of this thing. Drop space is in this case because of splenomegaly.
Yes, sir.
Yeah. Some examiners can ask you to draw drop space, borders of drop space.
So, sir, it is a semilunar space. The upper border is formed by sixth rib, and
Okay.
the lower is formed by the left costal margin, and on the left side it's by mid axillary line, sir.
Okay. Fine. Now what did you mention about any like uh, surfaces, margins and all in a palpation?
S-
You couldn't palpate liver at all.
no, sir, no.
Okay. Spleen. Okay. Fine. Okay. Yeah. Make sure about, like if you're palpating liver, you should tell about margin, surfaces, consistency of liver also. Okay.
Yes, sir, yes.
Yeah. Okay.
So, shall I proceed?
Yeah. Go on. Go on.
So in auscultation, normal bowel sounds were heard. There was no venous hum or any other added sound. And parectal examination and testicular examination was denied by the patient.
Okay. What can you get by doing parental examination and testicle examination?
So test per rectal examination to look for any peritoneal mets can be in a case of peritoneal carcinomatosis. Blummer shelf is seen.
Okay.
And
So, but
testes.
this is the case. In this case, is it significant?
No, sir. I actually I did it too because there is a cause of ascites as
Yeah, there could be another cause of ascites also apart from this chronic liver disease. We don't know.
yes, sir.
Yeah, but that is the reason for parental examination. Okay. What about testicle examination?
So testicular atrophy can be a sign of CLD in itself.
Yeah. Loss of testicular sensation, testicular atrophy, and testicular malignancy also you can examine and tell the cause of to say the cause of ascites.
Yes, sir.
Okay. What is the venous hum?
Uh, so due to the hyperdynamic circulation, there we hear venous hum that is called Carvallier-Baumgarten in case of
Two-wheeler,
CLD.
Baumgarten. Yeah. Okay. That is because of what is the collateral for hypertonic circulation.
So hyperdynamic circulation.
Okay. Any other what other added sounds you hear commonly?
So there can be bruit.
Okay.
There can be succussion splash.
Succussion splash for
No, in auscultation we have to check for succussion splash.
in what case it is important? Succussion splash.
Sir, in if there is a suspicion of hiatal hernia, sir, it can be found,
Okay. Yeah.
or
Thank you.
hypertrophic pyloric stenosis.
That is the gastric outlet obstruction.
Yes, sir.
Okay. Predominantly venous some any bruit or any friction rub. These are common sound. Friction rub also like generally that is friction rub mainly explained for this gonococcal hepatitis actually. That we see very rarely.
Yes, sir.
One is hearing friction. So whenever if examiner asks these things, you tell first. What are the added sounds means we have some arterial bruit and friction rub. Succussion splash and all case based that is mainly the surgical cause, not in our okay.
Okay, sir.
Yeah, go on.
So, so systemic examination, there was no significant finding. CNS examination, higher mental functions were normal. There were no flapping tremors, and Babinski was flexor bilaterally.
I could examine Babinski.
Sir, it can be found a bilateral extensor in hepatic encephalopathy.
Patient says not have any altered sleep pattern or anything like he didn't give any step any issue suggestion of therapeutic encephalopathy, right?
Yes, sir.
Then you need not to mention. What
Okay.
is more important here? Doing many mental examination.
Yes, sir. To check for any
I mean, sorry,
constructional
not
apraxia.
construction of exam is for construction of apraxia. Minimal hepatic encephalopathy, not minimal examination. MHE, minimal hepatic encephalopathy examination. That is with construction of apraxia.
Okay, sir. Yes.
Asking for number connection test, number figure test. These are important than Babinski. Plantar extensor in patient is having chronic encephalopathy. But patient is conscious oriented, he is not given any history of altered speech sleep pattern at all. So you should elicit minimal hepatic encephalopathy than these. Okay.
Yes, sir.
Anything else in CNS? Patient is chronic alcoholic.
Strexis we can test for.
That is also encephalopathy. Apart from encephalopathy, any cerebellar alcohol gamma is cerebellum, right?
Yes, sir.
Anything about neuropathy, peripheral neuropathy, anything about
Alcohol
post-column?
can cause alcoholic neuropathy can be a
Yeah,
cause.
you should check for post-column sensation. Like, not about checking. If examiner asks, you should tell all these things.
Yes.
Patient alcohol intake. What are the involvement of CNS in patient alcohol liver disease? These things, cerebellar thing, post-column sensation, and peripheral neuropathy. These are all you should keep in mind. Okay.
Yes, sir.
Now, what about CVS?
In CVS, there can be, as a complication of CLD, there can be hepatic hydrothorax. Oh, in CVS, it can be cirrhotic cardiomyopathy.
More than that, patient is alcoholic, right? Is there any possibility DCMP, dilate cardiomyopathy?
Yes, sir, dilated
You
cardiomyopathy
have to
also.
ask, you can examine, you can tell that you examine for S3.
Yes, sir.
Yeah. What about respiratory?
It can be due to, sir, pleural effusion or
Okay.
hepatic hydrothorax in this case,
Hydrothorax. Okay.
and hepatopulmonary syndrome
Uh,
and
exam.
portopulmonary hypertension.
Pulmonary hypertension, how can you tell with examination?
No, not by examination, sir.
This is examination, right? In
Yes.
respiratory system, what all things you examine in patient with CLD? Auscultation of chest by to say hydrothorax is there or not. Saturation, examination of saturation, and the
SpO2,
club.
yes, breath
Yeah,
sounds.
that's these are things very important in other system examination. Okay. Yeah.
So, so,
Anything, Dr. Deep?
Yeah, only one point. You might not get your notes. They will take your notes and then they will tell you to give the
Yeah.
history. So I mean, try to remember things and try to present without your notes. Right now, you are reading.
Be
But in
yes, yes.
exam, mostly they will take your notes and you will have to present without your notes. Okay.
Be prepared always without looking at notes. Presenting without looking at notes. Not now, but be prepared in that mode.
yes, sir.
Yeah.
So,
So provisional dialogue analysis, you will say without reading it. Start.
okay, sir.
Mm.
So, this was a case of a 54-year-old gentleman who had a history of significant consumption of alcohol for past 20 years, and who presented with complaint of abdominal distension for the past 1 year and one episode of hematemesis 10
Sorry,
months
I would
back.
stop you right here. So now you have done history examination everything. Now you can use your terms
Yeah, yeah.
like ascites, portal. I mean whatever varicose bleed, whatever you are trying to say. Now
Possibly
you can
ascites,
use your
possibly varicose bleed. You can use these terms.
Okay, sir.
now you can use these terms. You don't need to repeat it again in patient's words. So start again.
So, a 54-year-old gentleman who had a history of significant consumption of alcohol for past 20 years presented with history of ascites for past 1 year, single episode of upper GI bleeding 10 months back, along with a history of tapping at that time, ascitic tapping at that time, along with bilateral pedal edema for past 2 months, diarrhea for past 7 days, and oliguria for the past 3 to 4 days. And on examination, the positive findings were pallor, bilateral pitting pedal edema till the shin, significant number of spider nevi, gynecomastia, and uniform abdominal distension with fullness of flanks. And the on examination, the flow was from center to periphery, and there was
Sorry.
shifting.
Again, no need to mention all these things. We have heard all this.
Okay,
So
so the
based
diagnosis.
on your examination, what is, I mean, he is now decompensated in forms of all these things. Just in one sentence, slowly. Okay. Summary is very important. So history portion you covered well. Again, start from
You can
examination.
even cut short the summary.
Yeah.
Going like big story, you can even cut short, even cut short.
So in examination, should I mention shifting dullness and splenomegaly?
Yeah, that's all. Those 2 points over, no? Shift balance is there, and splenomegaly is there. That's all.
So the provisional diagnosis is decompensated chronic parenchymal liver disease, secondary to alcohol as an etiology, along with ascites, portal hypertension, and probable SBP.
Very good. So that is what important is. Chronic liver disease is your diagnosis, cirrhosis or whatever. with current decompensation in form of these things. Yeah. So you did it well. Okay.
Syndromic diagnosis, etiology, then complications. These are the order to tell the diagnosis. Good, good.
Okay, sir.
One more thing, like gynecomastia, you told, right?
Yes, sir.
Is it happening with any drug?
In CLD itself, sir, it can happen due to
Yeah.
spironolactone that we give.
Okay, that's what that. Gynecomastia could be because of drug also. Okay, okay. Just I want to add in between.
Just because gynecomastia is, I mean, just read for gynecomastia, how to look for gynecomastia, how to, these things you should know. Okay.
Only thing is drug induced, it will be very much tender.
Yeah. So tenderness and non-tender, that is
Yeah.
the point that tells you whether it is because of this or that.
Okay, sir.
Sometimes. Sometimes. Yeah.
Yeah. In complications like you, as we discussed earlier, recent worsening, cause of recent worsening might be new onset development of SBP,
So next
possibly.
question will be, what are the causes of sudden decompensation, which we
Yeah,
already
that's
discussed.
we
Sudden
discussed earlier.
decompensation in cause of in a case of liver CLD. Uh, okay.
Yes, sir.
All the pathophysiology, majority of pathophysiology you should know. Why portal hypertension, what varicose bleed,
Yeah, these are all actually
SVP.
theoretical. You should read and you should remember all these.
Yeah. Any questions now can come. So actually, so far you have done well. Mostly you will reach to this part, and now your theoretical discussion will start. How will you manage? Why this happened? Why that happened? And that means you have done well so far. Okay.
Okay, sir.
If you
Yeah.
comfortable reach up to here, you are nearly like more than past. Like, it's like you done pretty well. Like.
So how will you? For example, just for example, patient is still taking alcohol. How will you tell him to stop alcohol? How will you help him? What all things you will tell him? How will you help him?
Sir, first we'll check the cage criteria
Mhm.
or the audit score. Cage criteria, sir. If it's more than two, then it is suggestive of alcohol use disorder.
Yeah, so read about that also in detail. At least basic point. You should not get stuck
The
there.
thing
Okay.
is, the terms like alcoholic and all they removed now.
Yeah.
To say it is alcoholic, patient should have dependence. Dependence by any of those case audit score. You should satisfy those criteria. Then only you can say patient alcoholic. If not, it is basically alcohol use disorder. Dependency is something like patient is not able to tolerate without alcohol intake. But patients with cirrhosis, all the patients with cirrhosis, they are not actually dependents. They are with alcohol intake. That is alcohol use disorder. This is the new term, alcohol use disorder. This is different from alcoholic. Don't label it as they label as alcoholic. The term alcoholic is removed. If the patient is having a dependency, then only the word alcoholic is correct.
Yes, sir.
Okay. So management aspect.
Any drugs you can give to help with alcohol?
Sir,
Read
if
about.
it hello,
Three
Why?
approved drugs are there.
sir, if it's alcoholic hepatitis you are asking about.
No,
No.
no, no.
Alcohol quit. Cessation.
Quitting option alcohol cessation. It's not alcohol.
Disulfiram we can give.
Three approved drugs are there for this thing. One is
So,
naltrexone.
so if this case is there, you will be definitely, most probably
Yeah,
will
yeah.
be asked about alcohol
Yeah.
also. Even if your patient is not
No,
taking, it is a
your entire
common
discussion
disorder.
can be with alcohol. Whole
It
one
can be
hour,
only on
1 hour.
alcohol also. Yeah,
Exactly.
definitely. So read alcohol in detail. Okay.
This quantification we didn't ask still, but keep in mind.
Okay.
Are you
Dr.
there?
Arpan, I think he's not there.
Yeah, he resigned. He resigned.
Yeah, he has joined. Yeah. Dr. Arpan, can you hear us?
Yes,
You
sir.
are mute. Okay. So alcohol use disorders, how to do alcohol cessation, drugs required, doses, everything is required here. Okay.
Okay, sir.
Yeah, just read it. It is very important. Your whole Viva can go on alcohol only
Yeah.
from now
This
onwards.
is
Okay.
actually new things. So the answer about asking these questions: alcohol use disorder, audit score, case questionnaire, and all.
Okay, sir.
What about options? And management aspect: alcohol cessation and the nutrition and management of complications. Each complication, varicose bleed to prevent varicose bleed, and management of ascites and complications like hepatorenal syndrome. And all. These like you should tell detail in management part. And last thing, definitely about liver transplant.
Okay, sir.
Yeah, this is just like you should mention if they ask about management plan. This is the order of the management plan.
Yes, sir.
So how will you manage this patient? Let's try to finish it fast.
Yeah, yeah.
So, so if I'm considering SBP in this case, so I would start with.
So you have to prove SBP first.
Yes, sir. First, I'll get paracentesis done. And if the count is more than 250 cells and it's monomicrobial in culture.
You will leave the theoretical part, just clinical you tell. Yeah.
What antibiotics you will give?
You take the sample and start empirically.
Yes, sir.
What is the common antibiotic you use for SBP?
Hello.
Yeah, what antibiotics you will give?
You give cefotaxime, right? You there? Are you there?
Hello.
Dr. Arpan?
Yes, sir. So, sir, in the antibiotics, we if it's a community acquired, we are thinking in lines of then we can
No,
give.
no, no. If now this is your patient and you are the doctor, you tell
Yeah.
me what antibiotics you will give.
So, cefotaxime we can give
Okay.
2 gram TDS, and if there is any previous history of recent antibiotic exposure, then we can give piperacillin tazobactam.
Okay.
Then I would give. Okay. So one thing you are planning to treat SBP. Okay. What else you will do?
And we'll consider for prophylaxis, sir.
Okay.
Prophylaxis of SBP.
How?
Once the patient,
Yes, sir.
okay. Once the patient record from SBP, you want to give prophylaxis. What are the different indications of SBP prophylaxis in CL?
Sir, if the because SBP, sir, has a 70% recurrence rate, so in we should give prophylaxis
What
in
are the
those.
different indications?
Uh,
There are three
so
indications.
exactly, I don't know that
Recent
indication.
history of SBP, recent history of GA bleed, and acetic fluid protein more than 1.5 gram.
Okay, sir.
Yeah, for each of these things, there is a different time period to give prophylaxis. If patient has at least one episode of SBP, patient should need lifelong SBP prophylaxis. Once the patient recovers from particular first episode of SBP, the other two things there is a limited period of prophylaxis. Okay,
Okay, sir.
read about this SBP prophylaxis.
Yes, sir.
Anything else you would do?
The alcohol cessation.
Yeah. So you
Hmm.
will make sure that patient is abstaining again.
Yes,
Okay.
sir.
Each time you will make sure that he is not taking alcohol. If he is
Yes.
taking, again, all these questions, all these things will start. What all things you will give, what medicines, what drugs, everything. So alcohol is very important. You will definitely say you will start with alcohol sedation. You will give SBP treatment as well as prophylaxis. Then CLD wise, what things you want to give?
So we will
Anything else?
man.
I mean, what else you will do next?
So we will manage. We will manage ascites.
You didn't mention much about this diarrhea, acute GE, and decreased urine output. We didn't
Yes,
concentrate much on these things.
yes.
That might be the main reason for this sudden worsening of symptoms.
So
Are you getting?
Yes, sir.
He might be having acute GE, some sort of infection. CLD is immunocompromised state, right? They'll get developed easily prone to infection.
Okay, sir.
Okay. So you have to consider management of acute GE, and you have to check for renal parameters. If patient is having decrease urine output and renal parameters. That is my you should check for cause of this renal parameters. It's SBPR is because of vascular compromise of big sudden because of acute GE.
Okay, sir.
Yeah, you should manage in that line also.
CLD management.
Sir,
Next
we
you
will
tell.
also yes, sir.
Every
Okay.
Go ahead.
So we will consider if it is a refractory disease, we will consider for liver transplant.
No.
Just a
That's what.
second.
Don't
Before
invert
that,
the questions again yourself. So you here you told refractory. What is refractory? Refractory ascites or something. Maybe they'll ask you again what is refractory ascites. You start with ascites management first.
So with
will you
ascites
consider
management,
liver transplant right now for this patient? Are you
no, no, no,
considering?
no, sir,
Yeah,
no, sir.
so that is not what I asked.
Okay.
For
So with
CLD, what else you will do? Yeah.
so for ascites management, sir, we will start with sodium restriction. And sir, we will start with diuretic. We will start spironolactone, and if possible, with the combination with furosemide. Furosemide,
Once acute gastroenteritis is better,
yes, sir.
Yeah.
or SBP is
So
better.
to start diuretic, there should not be any infection. There should not be any hypotension. There should not be any renal compromise.
Yes, sir.
But diuretics and beta blockers both. These are the mandatory things.
Okay, sir.
Why is it spironolactone or loop? Which is preferable?
Spironolactone or
Loop diuretics.
Loop, loop.
spironolactone, sir, because CLD
Why?
is a state of hyperaldosteronism.
Yeah, good, very good.
So
Either
this time you
spironolactone
start
alone or
mentioning
combination.
faster. When somebody asks you, how will you manage this patient? You must not stop. You don't let them talk to you. You only speak. Sir, I would like to make sure that he is abstained. Sir, I would like to make sure that his SBP is controlled. I would do this many tests. I will do this, that, whatever. I'll start with CBC culture, whatever you want to say, but you don't stop. You continue, and that's how your sir. Next thing I would do is I would like to, for his CLD, I would like to start him on later on, once he is better, I would like to start him on aldactone plus or minus this, and I would like to add silacar or whatever prophylaxis beta blocker you are trying to give. Everything you should keep talking and talking. Don't let anybody ask questions there. They can ask you definitely, but you should not take any pauses. Okay.
So the flow should
There are
not
so
miss.
many
Then
things
only
to tell you. You want to tell them that you know things, right? This is the time you tell them that you know all these things. So you start speaking, okay, with confidence, and you
Yes.
just start speaking like that. Okay.
Yes, sir.
Yeah. Anything for complications of those? That is, one is portal hypertension. So we already said beta blocker and all. Other is SBP. We already said hepatic encephalopathy. If he is having hepatic encephalopathy, or to prevent, what would you do?
Sir, lactulose we will give. Rifaximin we will add.
Sodium, potassium, anything? You will make sure that electrolytes are controlled, because that can precipitate
Precipitate
encephalopathy.
hepatic
what are the
encephalopathy.
risk factor for
What are the
encephalopathy?
risks? Yes.
So risk factor can be electrolyte abnormality, mainly potassium abnormality.
Okay. How does hypokalemia or hyperkalemia, which is causing encephalopathy?
So hypokalemia.
Okay. How does hypokalemia cause encephalopathy?
So it it favors intestinal stasis. So intestinal motility is decreased. So that
Okay.
will
That is common answer, but that is not exact answer. Can you read? It's not
so,
only about reduced motility and stasis of fecal matter. Something else is there.
sir, I don't know that. Sorry.
Yeah, that's what creation of alkalosis.
Okay, okay, sir.
You read the mechanism.
And so infections can precipitate
Constipation, GI
GI
bleed,
bleeding can
infection. These are the main things. To
yes.
precipitate encephalopathy. You should make sure that they should not be there to prevent encephalopathy. electrolyte imbalance. Okay.
Yes.
Read about potassium hypokalemia and what does it have ammonium ions. How does it help to uh, how does it causes encephalopathy in hypokalemia,
Yes, sir.
and what the lactulose does in the colon to reduce encephalopathy.
Yes, sir.
Okay.
Yes.
How acidic environment in colon helps to prevention of hepatic encephalopathy. These are very much important things. Don't say only reduced motility when it's a hypokalemia. Okay. Read about this.
Sure, sir. Yes.
Yeah. Yeah. Okay.
And sir, we will check for and we will do surveillance for HCC also as a complication.
How frequent you do the SCC surveillance?
We will check for AFP levels and we
How,
will do ultrasound.
how frequent?
So frequency, I don't know, sir.
At least once in 6 months.
Okay, sir.
By ultrasound. If
Ultrasound and
if
AFP
there is any
levels.
doubt, do a. In real time practice, these are very difficult actually. Everything is expensive, right? Patient is cannot get repeatedly these two tests every 6 months. You have to convince them somehow. So do ultrasound and any anything suspicious, then go for this. Okay.
Yes, sir.
Hey,
Read about hepatitis B also. Huh?
yeah,
This case was alcohol, so we have asked only about alcohol and everything. Hepatitis
yes.
B.
We didn't touch much about hepatitis.
Mm.
Okay.
This is a rule out still. Okay.
Yes, sir.
Anything else, Dr. J?
Yeah, I think you did well. I
Yeah.
liked your histories.
It's a
Your
good
points
presentation.
were
Decent presentation.
yeah. So your points were, for example, if you are talking about admin distinction, you had covered all the uh, required questions that you need to consider. So your history was good. What I would like to tell you is keep your history like a story. The person who is listening to your history should visualize that these things are happening to the patient. Okay, this happened, then this happened, then this happened. Uh, that is uh, that is how you should present. No more negative histories, only important, relevant negative histories only. Next point was you did well. Summary also again keep it crisp. Whatever only important things that you can decide based on your history, that much DDs only. No need to give unnecessary more DDs. Whatever you
Okay,
are
sir.
saying, you should be able to justify or why it is not that. That two parts you should be able to describe.
Yes.
Uh, be confident. So today's history, what I could feel was you are taking deep breaths again and again. That shows that you are more. It happens. I mean, it happens to everybody. But what you try to do is you try to look more confident. So don't take too many pauses. Don't take too many deep breaths and all those things. Try to avoid that. That can happen still, but try to avoid doing that. No
Sure.
more hand movements. Hand movement should not be too much. It should be minimal. So what I used to do is I used to keep my hand behind only, both hands behind, so that I'm not using my hand again and again. That does, sometimes some examiners does not like that. Okay, so
Okay,
no
sir.
more hand movements. Be more active in the sense question is asked, you start saying two, three, four, five things immediately. You say one thing, you take pause, you say another thing, you take pause. Instead of that, better way of doing is to give answers rapidly, and then the next question will come immediately, or they will ask you to move ahead. They know that you already know this thing, let us move ahead, like that. So that is the thing. Otherwise history was well presented. Next point, examination. Basics, make sure basics you are not stuck anywhere. There will be only one or two question, but you must make sure that you move on very fast from there. So for that you will have to read, but there should be no problem in your basic examination. Your answers, whatever question is asked, you should be very quick to give answers there. There you cannot show that your basics are not clear.
Yes, sir.
Systemic examination, you did well. Your answers were good. Your pathophysiology, I think you knew well. You knew your subject well, so that was good. Then last point, if you reach there, I mean, when you reach there, so summary should be very crisp, and there you should write, I mean, say whatever is important things in your words, not whatever happened. Everything summary does not mean everything positive findings to be said again. What all things have happened, and basically what is your etiology, uh, current diagnosis, and complications. What is the status of complications? Management, make sure whenever you get a question, how will you manage this patient? Then it's your game. You should start speaking things so fast that they just listen to you and they don't need to ask you anything, whether you will treat or not treat this thing, or why did you forget this. You start speaking maximum things when you get this question, how will you manage this patient? Okay.
Yes, sir.
Yeah. Dr. Sivaram.
Yeah, fine. Good. It's a good presentation, Doctor.
Thank you, sir.
Okay.
These are valid points discussed by
Akif is there?
Dr. Hello.
Akif, are you there or not there?
Yeah.
So I think we can close this session
Yeah,
now.
yeah.
Yeah.
Thank you so much, sir.
Yeah. When is your exam?
Sir, it's on 30th.
Oh. Oh, okay. I
Okay.
did not know that it's so soon.
Yes.
In that
Oh,
case,
okay.
yeah, you did well actually. Your content was, your theory, I think, is very good. What you need to do is show that you are more confident. Okay, that is all
Okay,
you
sir.
need, and be more quick to answer. Okay.
Okay, sir. Yes.
Chalo, all the best.
Yeah, all the best,
Thank you,
Doctor.
sir. Thank you so much, sir. Thank you.